On-the-scene video coverage of TCT 2012 is supported by Pradaxa.
Thank you, Ajay. Good morning, everyone. So it's a privilege on behalf of Greg Stone, the study chairman, and Chuck Simonton, who conceived this before leaving for industry, and the ADAPT-EES investigators to present the one-year results of the ADAPT-EES study, which is the assessment of dual antiplatelet therapy with drug-eluting stents. And this was a large-scale, multi-center, prospective observational study of the impact of Clopidogrel and aspirin hyporesponsiveness on patient outcomes. These are my disclosures. So a little bit of background. Although prior studies have shown a correlation between platelet hyporesponsiveness to ADP antagonists and stent thrombosis, all have really been pretty much moderate in size. So the objectives here were first to determine the frequency, timing, and correlates of drug-eluting stent thrombosis in a patient population with few restrictions. And secondly, to evaluate the relationship of aspirin and clopidogrel hyporesponsiveness to early and late DES thrombosis in separate phases, stratified by whether the patient was taking dual antiplatelet therapy or single antiplatelet therapy. So, for example, many patients take dual antiplatelet therapy for the first year and are restricted to aspirin after the first year based on the guidelines. So this prospective registry started off with 11,000 patients as a goal. It was stopped at 8,600 patients primarily due to funding reasons, and this was performed at 11 sites in the United States and Germany. And to be eligible, patients had to have implantation of at least one non-investigational drug-eluting stent, and it had to be successful and an uncomplicated procedure. They then underwent platelet testing using the Acumetrix Verify Now testing methodology with which many of you are familiar. And clinical follow-up was done at 30 days, 1 year, and 2 years. So, based on best fit criteria, platelet hyporesponsiveness was defined as a P2Y12 reaction units of greater than 208, which defined platelet hyporesponsiveness. And this is the first slide, which demonstrates a significant difference in stent thrombosis in patients who are considered hyporesponsive to those that were considered responsive, with values of 1.3 versus 0.5%, which was highly statistically significant. Similarly, the rate of myocardial infarction independent of stent thrombosis was about 1.2% higher in patients who were considered hyporesponsive. But in contrast to that, there was a significant reduction in overall rate of major bleeding in patients who were considered hyporesponsive. So that was 5.6 compared to 6.7 in patients who were considered responsive. This slide shows the multivariable predictors for all-cause mortality, and as you can see at the very bottom of the slide, definite stent thrombosis, myocardial infarction, and major bleeding were strongly significant predictors of all-cause mortality. In contrast, patients who were considered hyporesponsive, the rate of stent thrombosis was significantly correlated with that, and the rate of myocardial infarction was significantly correlated with that. But this was protective against major bleed, and as a result of that, all-cause death was not significantly linked to platelet hyporesponsiveness. This shows the relationship of aspirin hyporesponsiveness defined as an aspirin reaction units of greater than 550, which is a fairly standard definition, to subsequent one-year adverse events. And as you can see, it was not linked to stent thrombosis, and it was not linked to myocardial infarction, and, interestingly, was protective of major bleeding. So in summary, in the large-scale prospective ADAPT-EES study, on-treatment hyporesponsiveness to clopidogrel after DES was an independent predictor of one-year stent thrombosis and MI, but was also protective against major bleeding, both of which were strongly related to mortality. As a result, on-treatment clopidogrel hyporesponsiveness was not independently predictive of one-year mortality. Overcoming clopidogrel hyporesponsiveness with more potent antiplatelet agents is therefore unlikely to improve survival unless the beneficial effects of reducing stent thrombosis and myocardial infarction can be uncoupled from the likely increase in bleeding with greater platelet inhibition. And finally, hyporesponsiveness to aspirin was unrelated to stent thrombosis, MI, or death, but may be related to bleeding, questioning the utility of aspirin in patients treated with DES. Thank you.
Great. Thanks so much, Tom. Let's go questions from the press.
Crystal Fenn with MedPage today. Question perhaps for Dr. Jacobs and Feldman. What do you think clinicians should do with this information? Is there anything that you would tell them?
This is an even bigger tangled ball of yarn than PFO, I think. And to make an analogy, there are several strands coming out of the tangle, and we're all trying to figure out where to pick up a strand and start unraveling it. So this is, I think, more data in the pool, but definitely is a glimmer and not a big blast of light. So from a highly pragmatic standpoint, my personal reaction is I've been waiting to buy a bedside platelet function assay testing machine, and I think I won't feel guilty about waiting a little longer.
Alice?
So I agree with Ted. That's why I asked him to answer first. This is a very nicely done study, so congratulations on that. What I see are new data are the bleeding, because the conclusion last year was a little bit different, that it was, it was a little bit more proponents of the newer agents. And I think this just adds to the underpinnings of the conundrum that we've seen with these newer agents that we're matching. We haven't gotten that sweet spot. We're matching the increased efficacy but the problem with bleeding. So I think these data will be, added to the pool of data, and I don't think it's going to change anything immediately.
Great.
I have one other short comment, and that is that the idea that aspirin was protective against bleeding is, I hope, illustrative of the same kind of finding that we saw in one of the very early thrombolytic therapy for acute MI trials, where stratification of outcome by zodiac sign was performed, and Libra patients did better without aspirin than others, some goofy finding. And it's hard to buy that aspirin's protective of bleeding.
Well, there are other studies that have shown that, look at WOST, look at, numerous trials have shown that it's protective. The question is can we abandon aspirin after a DES patient? And that obviously is not going to be answered by this.
Bert Cohen from angioplasty.org. What was the definition of major bleeding in the trial? And although unrelated to the trial, does anyone have suggestions as to, how to tackle the problem of major bleeding? What strategies can be employed?
One thing that I think, first of all, I'll answer the second question, then I'll go back to the first one. The one thing I think about one of the important things is the issue of uncoupling. So, what we're trying to do is gain the advantage of newer and better agents, but uncoupling them from the bleeding issue. And there's a lot of issues related to that, with the timing of the bleeding, the type of the bleeding. Is it procedurally related? Is it later related? And I think if you attack those things as different issues, there may be a sweet spot where you can define people who are and are not at risk for bleeding, and then target your therapy like we have in many other areas, from treatment to prevent cryptogenic stroke to everything else. And I think that that's going to be the issue, to try to develop ways to uncouple that. So I think that's the issue. The other thing I would say about the current importance of this particular data is that, with aspirin, with the clopidogrel now costing about $13 a month in the United States, I think the issue comes back as to, what are we going to do? With regard to the major bleeding, It was not adjudicated, and it was site reported. So that's going to be an issue in the long-term analysis and the development of the paper. It was on the case report form for both TIMI major and minor, as well as the Gusto definitions and some of the acuity things. And then it was site reported afterwards with regard to long-term follow-up. So at least from the initial set of data that we have from 1 year, a lot of it is up front, and I think I don't know if you have any more comments about that.
Yeah, so just for the sake of disclosure, I don't have any industry conflicts, but I was involved in the analysis of this trial. But that having been said, it is interesting, even though it's site reported, that it was independently associated with mortality. And there are other studies that have looked at this issue of bleeding, and there are links between hyper-responsiveness or adequate responsiveness and bleeding. And I think that's the real issue here, is that we know that this is a risk factor. Sam and others have shown that hyporesponsiveness is a risk factor for ischemic events, but the therapies that we have to treat those ischemic events, more potent antiplatelet therapies, do increase the risk of bleeding. And so we have to figure out in whom should we use those therapies.
You go ahead.
It's a mixture of access, non-access.
Just a point of clarification, again, for time, I'm sure you didn't show it, but your propensity analysis, did you match patients on all of the predictors of stent thrombosis?
Yeah, 87 different predictors were pushed into that model.
And you had the requisite standardized difference of less than
Yes.
10%?
Yeah, Greg will show that in the presentation
Thanks very
later
much.
today. Great, thanks so much.